So if race and ethnicity are cultural constructs, how does that help us understand health? Because there are some real differences in health among ethnic and racial groups, not just here in the United States, but around the world. In the United States, Black and Native American and Hispanic people all have higher rates of diabetes than white people do. And they are about twice as likely to die from it. Asian people, by contrast, have lower rates of diabetes, and both lower rates of incidence and lower rates of mortality. Cancer rates differ as well, though it depends on which cancer you're talking about. Black and white women are about equally likely to have breast cancer, while Asian American and Native American women have significantly lower rates. The lowest rates of all are found among Hispanic Americans. Black men, by contrast, are much more likely than any other ethnic group to have prostate cancer, while the lowest rates of that are found among Asian Americans. Now, skin cancer is highest among white people and lowest among Black people. Mental illness doesn't vary that much among different ethnic groups, but suicide does. While Native Americans have lower rates of adolescent major depression than any other major racial group in the United States, the rates of adolescent suicide are more than 3 times higher than the other groups. If you look through the medical literature, you'll find lots of data like this, indicating that ethnic and racial distinctions have significantly different health profiles and disease outlooks. You will also find some diseases that concentrate themselves heavily within particular ethnic communities. As we mentioned last time, for example, African Americans are much more likely than other Americans to suffer from sickle cell disease. That's a biological tendency, not a cultural one. Sickle cell occurs because of a particular mutation in the parts of the genotype that code for hemoglobin. Now, as we discussed before, this mutation gives you some protection from malaria parasites, and so it tends to develop in areas with high endemic rates of malaria. Now, that includes parts of Central and Western Africa, where many African Americans trace their ancestry, and as a result, it's found among a lot of African Americans today. Likewise, there are a number of genetic diseases that are common among Ashkenazi Jews. If you're not familiar with that term, Ashkenazi Jews, there are a couple of major cultural divisions among the Jews of the world, some of which are based on the history of the diaspora. I won't get into it, but well, since it's my field, I'll tell you. The short version is that when the Jews were expelled from Spain in the late 1400s, some of them went east to places like Germany and Eastern Europe, while others went north to places like Portugal and Holland. They were separated from one another for quite a while, and so they developed different languages and cultural customs and religious practices. The ones who went north are called Sephardic Jews, and the ones who went east are called Ashkenazi Jews. Now, the majority of the Jews in the United States immigrated here from Eastern Europe, so the style of Judaism you're most likely to encounter in America is Ashkenazi Judaism. Well, anyway, one of the diseases like this is called Bloom syndrome, and it comes from an irregularity in part of the genetic code known as the BLM gene. Some people have a mutation of this gene that produces a characteristic set of problems. Some of them are just cosmetic. People with Bloom syndrome are usually very short. They tend to have a lot of facial rashes, and they have a recognizable facial pattern with a long, narrow face, a pronounced nose, and a very small chin. They tend to have a few recurrent medical problems like immune deficiencies that make them very vulnerable to infections. The biggest problem, though, is their vulnerability to cancer. People with Bloom are vastly more likely than other people to get cancer. They get it young, and they get it very severely. The average lifespan of someone with Bloom syndrome is about 27 years, and the cause of death is usually cancer. This is a terrible disease, and fortunately it's a rare one, but it's rarer in some people than others. It's most common among Ashkenazi Jews. Jews constitute about 1/5 of the world's population, but they make up about 1/3 of the people with Bloom syndrome. Now, there are other health problems like this as well, and again, if you look at the medical literature, you can find references to all of them. Now, in the United States, we tend to think of race as a biological thing, as we said before, and so When we hear examples like this, we tend to conceptualize in biological terms. We say there must be something in the biology of black people that makes men more vulnerable to prostate cancer, and something in the biology of Native American people that makes them more vulnerable to diabetes. If we want to improve the health of these people, therefore, what we need to do is to do medical and genetic studies that are going to identify the source of those vulnerabilities and develop racially tailored therapies for curing them. As we said earlier, though, anthropology has demonstrated pretty convincingly that this biological model of race doesn't work. Races are cultural constructs, not physical ones. They're things we create, not things that we inherit. Racial and ethnic groups, moreover, are not in any sense stable. They're not the same thing today as they were 50 years ago, and in 50 years ago, they will be something very different again. So as anthropologists, how do we account for the kinds of variation that you find in the health characteristics of different ethnic and racial groups? Well, there are three basic approaches to answering that question. The first is to notice that race is often a proxy for other kinds of social differences. Wealth, for example. It's often distributed very unequally among different racial and ethnic groups. In the United States, for example, the median household income for a black family in 2014, was about $43,000. Now that's compared to a median household income for a white family of $71,000. Now, that's just income. If you look at total wealth, it's much more stark, right? Total wealth includes not just what you make, but your assets, what you have, your house, your bank accounts, and so on. The median wealth of a black family in 2022 was about $45,000, while the median wealth for a white family was $285,000. And the median wealth for an Asian American family was just over $536,000. Now, those figures, those differences have widened over the past decade, and they look poised to get bigger in the future. That doesn't just happen in the United States, of course, all over the world. Different racial and ethnic groups have different economic resources. The particular ethnic groups involved, of course, vary culture by culture. In England, for example, census authorities distinguish between Asian Britons with roots in Pakistan and Bangladesh, who earn much less than white Britons, and Asian Britons with roots in India and China, who earn much more. In Rwanda, the distinction between Tutsis and Hutus has strong economic associations. The wealthier Tutsi minority serving as merchants and landowners, while the Hutu population, who constituted the majority, tended to be poor farmers and laborers. Those kinds of differences, of course, translate into differences in health. In 2022, Native Americans and Hispanic Americans were more than twice as likely as white people to be underinsured or uninsured altogether. And that has powerful implications for healthcare. So does nutrition. 25% of Native American children and more than 20% of black children in 2022 suffered from food insecurity, compared to about 6% of white children. Now, those differences, of course, are much more stark in developing countries where wealth and poverty have powerful ethnic associations. Those Brazilian slums where Nancy Shepherd Hughes did her field work were almost entirely black, filled with the descendants of people brought in slavery from Africa. In India, poverty and disease divide among caste lines, with groups like the untouchables concentrated in dangerous occupations and substandard housing. In a lot of cases, therefore, the health differences that are associated with ethnicity and race don't come from ethnicity and race themselves. They come from the economic and cultural disadvantages that come along with them. Now, a second approach observes that while race may not make you sick, racism certainly can. In many cultures, racial disparities are associated with cultural and political discrimination that affects the health of disempowered minority groups. In the United States, for example, segregation during the Jim Crow era included segregation in medical care. In the southern states, many hospitals wouldn't accept black patients at all. Others did, but they separated the races, putting the wards for black patients in basements or in outbuildings where the facilities were radically worse. The situation was better in the northern states, but not a lot better, with restricted numbers of beds for black patients, and there was often a ban on black physicians or black nurses. Hospitals exclusively for black patients were established all over the country as a result. They included some really great institutions like the Providence in Chicago and the Harlem in New York, but their funding and the standard of care were dramatically lower than those for white hospitals. In 1944, out of 110 black hospitals in the United States, only 22 of them were actually approved by the American College of Physicians and Surgeons. And the result, predictably enough, was a difference in health outcomes. In 1944, there was one hospital bed available for every 1,000 black Americans. There was one available for every 110 white Americans. Now that meant, among other things, that birth usually took place at home for black women and in hospitals for white women. And for complicated deliveries, that could be a fatal difference. The rate of maternal deaths for a white woman in 1940 was around 319 per 100,000 live births. For black women, it was just over 780, about twice as much. Infant and child mortality, likewise, was around 70% higher for black children. Now, more subtle effects came from practices associated with housing and employment. In the 1930s, for example, the Federal Housing Administration began to standardize risk assessment for home loans in an effort to make mortgage rates more predictable and prevent defaults. Now, to do that, they commissioned the Homeowners Loan Corporation to draw up maps of 239 cities and to classify the different neighborhoods according to their lending risk. Now, the riskiest ones, the ones where it was most likely that the person was going to default, were called Type D neighborhoods. It went A to D. And they were outlined in red on the map. And this is the origin of the term redlining. Now, those tended to be older neighborhoods in city centers, which is where black households tended to live. And as a result, in the entire United States, only 6 neighborhoods with a majority of African American residents were not redlined. Now, that meant, among other things, that it was very hard for black Americans to get home loans. And as time went by, a variety of institutions, including insurance companies, started also doing redlining, making it more and more difficult to keep housing in black neighborhoods well-maintained, safe, and well-insured. Now, this had predictable results on African American health. People were exposed to more toxins, like lead and paint and plumbing. They were more vulnerable to accidents and to crime. And since the neighborhoods were increasingly falling down, medical clinics and grocery stores were reluctant to establish themselves there. It also, since it was very difficult for African Americans to purchase homes in these neighborhoods, they didn't have the opportunity to build wealth through homes. That was a basic core of the method of wealth building for other parts of the United States. Now, this kind of discriminatory pattern is not limited to the United States, and it isn't limited to a single racial or ethnic group. Anywhere where you have patterns of racial and ethnic discrimination, and let's face it, that's pretty much everywhere. Anywhere you have that, you're going to have an impact on health. And a lot of the differences among ethnic groups in health traces to that kind of racism. Now, a third approach to ethnic differences focuses on the cultural patterns that are associated with behavior and their impact on health. You know, ethnic groups define themselves in large part by things they do differently from other people. You know, different ways of talking, different ways of using their hands, different ways of worshiping, different kinds of clothing, right? Some of these differences affect your health. Diet, for example. Almost every ethnic group defines itself in part by a distinctive culinary tradition. In the United States, you can get a sense of this by inviting somebody out for dinner. The first thing you'll discuss is the kind of food you're going to eat. You feel like Chinese, Mexican, Thai food, Italian. There's a French restaurant up the street, right? The idea is that each of these ethnic cuisines is something distinctive. Now, not all of them are named that way, but they still are associated with ethnic identities. Right? If you go to a deli in New York, it often means eating Jewish cuisine. If you go to a barbecue restaurant, that's often associated with African American cuisine. Now, that's not just reflected in restaurants, of course, but in homes. If you grow up within an ethnic group, that shapes what you eat. And that, of course, shapes your health. Nutrition is a basic element of health, and you would expect this to produce some variations, especially in chronic diseases. Things like pulmonary or circulatory diseases that are associated with nutrition over long periods of time. Now, we're running out of time. I promised I wouldn't go too long on this, so I'm not going to go into this in detail. But the point is that when we're looking at variations in health among ethnic groups, we can't just look at social factors like wealth or discrimination or housing patterns and so on. We also have to look at the cultures themselves to see how their patterns of behavior and their patterns of relationships affect their health, both positively and negatively. Now, what you'll notice about all three of these approaches is that none of them builds much on biology. There are a few biological tendencies, like a predisposition to sickle cell or Bloom syndrome, that do tend to be found more often in particular ethnic groups. But they don't define those groups. Bloom syndrome may be more common in Ashkenazi Jews than other people, but it's still pretty rare even there. African Americans may be more likely to have sickle cell than other Americans, but they aren't the only ones who do. The variation within any ethnic or racial group is enormous, and it's changing constantly, which means that there is virtually nothing about the biology of any group that gives you a reliable clue to its medical needs. There are indeed differences in health among races and ethnicities, just as there are differences in income, or occupational profile, or voting patterns, or anything that involves human behavior. Just like all those other things, we can't look for their origins in our genes. It's not what we are that determines our health, it's what we do, both to ourselves and to each other. Now again, we often don't like to hear that because it makes us feel culpable. It makes us feel like we are to blame for the things that we don't like in the world. But it also means that none of these patterns are written in stone. If people made them, people can change them. The real question when it comes to ethnicity and health is whether we are willing to do what's necessary to make that happen.